Good afternoon. I'd like to welcome you to today's Medical Center Hour, First Nations Resilience, Two Communities Take on an Epidemic. I'm Marcia Day-Childress from the Center for Biomedical Ethics and Humanities here in the medical school. We're so pleased to bring you this program. When the First Nations of Big River and Ahtahkakoop in Canada's Saskatchewan province realized their rural communities were in the throes of an HIV epidemic, their leadership and health centers rallied community members to determine the sociocultural and structural issues behind the epidemic. One of the driving factors proved to be injection drug use. Big River and Ahtahkakoop then developed culturally competent, community-based care to address the intertwined issues of HIV, hepatitis C, and substance use. In this presentation, spokespersons from these two communities describe how they took on these epidemics, and they will discuss solutions they devised that have worked for them. This program, which is both a Medical Center Hour and Medical Grand Rounds, is part of a larger conference being staged at UVA yesterday and today by the Center for Global Health and the Department of Medicine. Best practices in community mobilization in response to substance use and related epidemics. Serious infectious disease and epidemic substance abuse are much in the headlines these days. And indeed, 2 Medical Center Hours in October will examine aspects of the devastating opioid epidemic in the United States. But another good reason for this program is that it's an opportunity to cross cultures, to see how communities different from ours, but facing similar public health and personal health crises, have problem solved at a grassroots level in ways that are locally, culturally consistent and effective. It's an opportunity for us to recognize that health-related challenges to individuals and communities are never just biomedical, but rather biocultural in origin. And responding to such challenges, acknowledging, understanding, and managing them must therefore also be fundamentally biocultural. So what do the Ahtahkakoop and Big River communities' struggles and their culturally competent local responses offer us? Are there lessons from these First Nations for communities in Virginia, where on average 3 people die every day from opioid overdose, and more widely in Appalachia and other parts of our country? Are we, should we be, thinking bioculturally about our own epidemics, their origins, and our solutions? Our speakers today all hail from the Canadian province of Saskatchewan. They include, on my immediate right, Dr. Stuart Skinner from the Infectious Diseases Clinic at Regina General Hospital in Regina, Saskatchewan. You'll note in your handout that Dr. Skinner disclosed some financial involvement with pharmaceutical concerns in relation to his HIV and hepatitis C research. Our other speakers include representatives from First Nations health centers, from the Ahtahkakoop band Noreen Reed, who is on the far end, and from Big River, Leslie Ann Ironstand-Smith, closest to me, and Vivian Ruby McAdam. And they will present in sequence, and at the close we'll have some time for questions and discussion. So welcome, and we are here to learn from you. Thank you.
Well, thanks everyone for having us here. It's very humbling, and we're very honored to be here from 2 communities from a province in Canada you probably can't pronounce. But more importantly for us, it's rather than being, when people talk about HIV, or in Canada when people talk about First Nations health, it's often seen and described in a negative light, a problem-based light. And to be here and to talk about positives and how solutions were developed and developed locally and led by those First Nations is really an honor to be a part of the program. I'm an infection doc. I'm based in Regina. which is, I guess I'll take a step back. So this is our province of Saskatchewan. Regina is based in the southern, we're in the southern part of the province. So we're located near the bottom. And the two communities I work with, or two of the communities I work with, Big River and Ahtahkakoop, are about halfway up the province, about 500 kilometers away, it's about 400 miles away from where I am, and about 150 kilometers away from the closest city where you can get lab services and clinical care. Saskatchewan is a province, we're a prairie province, we're landlocked, we're in the kind of central part of Canada, just above North Dakota and Montana. Probably don't hear much about us. We represent about 3% of the Canadian population. I've basically got 5 minutes to describe to you our entire province, country's health system, and all the underlying issues relating to Indigenous peoples in the country. So I'll do my best to hit you the high level points. Saskatchewan's a province. We have pretty brutal weather. The summers are nice and hot and dry. It's a province based on agriculture, potash, oil, and gas. But the winters are long and cold. The summer's about 35 degrees Celsius, and I always say just put a minus sign in front of that, and that's what our winters are like. So often lots of snow, blizzard conditions, which makes travel and transportation, particularly for people in rural communities, that much more of a significant barrier when if you have to hitchhike to get your methadone, which is what many of our people have to do, and it's minus 50 degrees with the wind chill. Is that really practical that you could ever actually deal with your opioid addiction? The Canadian health system, I always say we have a public health system, so all your hospital care is provided, your clinical care is provided, medication isn't necessarily provided, allied health professional coverage isn't provided, so I'm not sure I would necessarily consider it universal health care, but it is all covered, at least in the hospital where you don't have to pay. But it's really a provincial mandate. So the system's set up where the federal government transfers the funding to the provincial health systems, and then the provincial health systems will decide how programs specifically are rolled out. Now, on top of all of that, and layered on all of that, for our Indigenous people, which is First Nations and Métis and Inuit, for reserve communities, which is First Nation communities, that's on federal land. So some of the programs are federal jurisdiction and run by federal First Nations Inuit Health Branch or Health Canada. But what happens is anytime you get federal or provincial, you end up in this jurisdictional vacuum where no one wants to take responsibility, and sometimes nothing gets done because there's just a bouncing back and forth of nobody actually taking the initiative to make a difference. In our province, we've had the highest rates in Canada for the past 10 years, fairly consistently. In the bottom left, you'll see a graph, which kind of, thinking as a vascular surgeon, a graph comparing the Saskatchewan rates to the Canadian rates. The Canadian rates have slowly been declining, but Saskatchewan rates have been pretty consistent. We're about 2.5 times the national average. The top graph kind of gives you the number of cases, and we haven't had unfortunately, we haven't had the investment of resources that are required. So while we had a bit of a reduction in our cases in 2013 and 14, the last bar on the right is your 2015 numbers, and 2016 actually went up again compared to 2015. Most of this is related to injection drug use, and because of that, we have similarly very high rates of hepatitis C. About 70% co-infections. For the communities we'll talk about today, it's about 90% co-infected with hepatitis C. What started as an outbreak in the urban centers, so Saskatchewan is 50% of people live in the urban centers. We have two major tertiary care centers, Regina, which I mentioned, Saskatoon is the other one, and the rest is kind of rural and outside. So we have a very much rural population with all the challenges that come with that. Most of the population kind of is in the bottom half of the province. When we think about rural communities, we're thinking about remote communities, you often think about getting in a plane and flying up north. But the reality is the challenges of a rural population are almost the same even if you're 30 minutes outside of a major tertiary care center. If you don't have a car, you have no access to transportation, and you can't get any access to care. And that's just one kind of context to put things in. So what happened was the epidemic started in the urban centers, and then what's happened is it's spread out now throughout the province. And we kind of see almost an outbreak situation kind of happening in various communities in our province, not dissimilar to what happened in rural Indiana a couple of years ago. I'll leave it to the team on the right to kind of talk about the specifics of the program. But what happened was it's really hard to describe the way Canada has treated their Indigenous peoples over hundreds of years. But let's just put it this way, it's been very poor. Remember, the communities are very much underfunded, and we have a lot of racism within our country, despite what Canadians may want to tell you. Saskatchewan has one of the highest kind of populations of Indigenous people, about 15%. Half of those live in First Nation communities, and half of those will live in the urban centers or other communities. But all of that led to the way the people have been treated, a lot of underlying poverty and resulting socioeconomic factors, and then the substance use that people will often develop to deal with all of that trauma that they've been dealt with through their lives. Despite this, despite having what traditionally people would think are the hardest to treat HIV population, active substance use, rural population, poverty, transportation, homelessness, we've achieved the 90-90-90 outcomes with UNAIDS that they've laid out, so 90% of people on treatment, 90% of people, 90% of people diagnosed, 90% of people on treatment, 90% of those undetectable. And in fact, we've reached 95, where the vast majority of people are on treatment. And while it comes and goes, there's ups and downs. There's been points and times where we've had every single person undetectable with a viral load. And that was done because these communities and the leadership in the communities who are here, and the nurses in the communities who lead the program, said, you know what, we need to do something, and we're not going to wait for government to make a policy or to make a program. We just need to do this, and let's do this. And really, I think any successful program comes down to the people in it, committed and passionate, and not waiting for other people to come up with solutions for them. So that's our situation, and to talk a little bit more about the specifics, I'll pass it on to you guys.
Good morning, everyone. I'd like to thank the organizers of this conference. I'd like to thank you all for attending today. I'm very humbled. Okay, great. So I'm a Health Canada nurse. I'm a federal nurse, but I work in the community of Big River First Nation, and we developed a Know Your Status right from nothing. And we've started it in January 2010. We started the program. I bring greetings from our chief, Bruce Morin, and our 12 council members. Bruce, unfortunately, was not able to attend with us today. But he's an amazing man, and he gives us so much support. So the Know Your Status program, I got a few minutes to talk to you about a program that I can present for hours. The Know Your Status, KYS is what we call it. Why did we start it? We started to see high-risk behaviors in our community. We've seen increase in chlamydia and gonorrhea, hep C, sporadic cases of HIV, and then we found a pocket of intravenous drug users and the prescription drug abuse, and the drug of choice is morphine in our area. One of the interesting things here, when I talk about high-risk behaviors, where people will say, well, how's chlamydia and gonorrhea associated with this? 98% of our clients that have HIV and hep C had chlamydia or gonorrhea in the beginning. And so at that time, that was already saying there was high-risk behavior there, and we consider that very much a target for clients not taking care of themselves, and everything's 100% preventable. So we decided that our clients, we needed to test. Our clients would not go for follow-up testing. We would diagnose them with something, and they wouldn't go for the follow-up testing, which is an hour away in a neighboring city, Prince Albert. We even tried the requisition in hand, where they had the medical health officer's number on it. They could just take the rec rate to a lab, bypass a doctor, a nurse practitioner, or anything, and that still wasn't working. Because there's so much fear and anxiety that goes with unfamiliar healthcare providers. They were seeing people and repeating their story, you know, I'm HIV, I need this done, and then they'd send them to the social worker, I'm HIV and I need this. And it just became they got mixed emotions having to do that all the time. So we also have poor access to primary care. We're in rural Saskatchewan, and like Stu said, we have just over 1 million people in our whole province. So to get to ID specialist, Stu lives 400 miles away from us. And so that was an issue, and so we decided in the end, leaving the community is not the answer. So we decided to have the Know Your Status program. We had a local logo contest in our high school. We had 68 entries from our high school students. A survey about HIV and what they knew about infectious diseases was sent out. Our students did remarkable because we educate them all the time. And the poorest surveys we got back were from the teachers. And so it showed that we needed to teach give our educators more information. So this was Trey Whitefish. He was in grade 11 at that time, and he created our logo, and we're very proud of that logo. So once we decided we needed this training and it needed to come from within the community, our clients are comfortable in their home communities, our nurses were trained, we're community health nurses, so it's like public health nurses. You don't do phlebotomy, you don't do diagnosis, and our nurses expanded their role, and so our nurses are the phlebotomists, our nurses do give diagnosis, and they do the complete case management of HIV, Hep C clients, and all the other STIs that go with it. We have a lab license, we're regulated, we just went through accreditation, so we're very proud of that. But this program was created one day at a time. We actually developed our forms, they're living documents, and they change every day with the needs of our clients and what we're needing in the program. We also need a client buy-in. You can develop a program, but that doesn't mean they're going to come. It's not the old Kevin Costner build it and they will come. We needed to get out there and develop relationships. Our clients needed to feel trust. They needed to know that when they came to the clinic, they were number one. I'm a firm believer, and I really promote this in our communities and with our nurses, that those clients are number one. We're not going to do anything unless it's for the benefit of those clients. So relationship and trust was key to success. Some clients were very quick to engage. Some took months to years. We would do numerous home visits, and we'd get lost, get off my land, get out of my yard, and we'd just say, all right, see you next time. It was just that you needed to develop that. Clients are scared when they have these diagnoses. And they need to know it's not a death sentence anymore. So the social determinants of health play a huge role in our HIV infection and the ability of our clients to seek treatment, care, and support. Many of our clients are couch surfers. They don't have a home. They live with relatives, and those relatives get tired of them. They move on to the next, and they move on to the next. So we have a large geographical area, so finding them at times is difficulty. But one thing I have to stress is our program does not create dependency. It creates ownership. Our clients, this is your HIV, your Hep C, this is your disease, what do you want to do with it? We will walk with you, we will talk with you, we will do whatever you need to get you to that undetectable and that healthy living, but you have to make the plan. And so we're just there to assist them. So like I said, January 6, 2011 was our first lab draw, our first KYS clinic. And our first positive client we tested had 23 contacts when he came back. 19 of those clients became positive. And that was from a weekend of sharing needles. And so we just knew how quickly this could spread if we didn't stop this. Daily screening is now offered. We completely case manage this client. Social networking to us is huge because we peel back the layer of the onion. Okay, so now we have you that's positive. Who's your social group? Where are we going with this? We need to stop this spread. And we need to do it with the client focused, like they're number one. So 3 months into the program, we developed this program without an infectious disease doctor tagged to it. We would diagnose our clients, we would get everything, but we'd still have to send them to the neighboring city. So our good doctor, Stuart Skinner here, who we absolutely love and adore, Stu phoned us and said, I've heard all the great things you guys are doing, I'd like to be part of it. So we didn't trust him at first, no, I'm kidding. Anyway, so Stu came in and he helped us build the program a little bit stronger because now you've got that physician service in there as well. And Stu comes out to our clinics every 3 months. And we have him packed from the moment he walks in that clinic till he leaves, and we keep him overtime sometimes to make sure that everybody's seen that needs to be seen. In between his 3-month visits, we telehealth our clients. So if we get a pregnant woman with HIV, or we have someone that has a low CD4, we'll telehealth those clients to get them started on medication. And it's very, the clients actually enjoy that. They just can't believe they can talk to their physician on that television, and it works really well. Because we case manage all aspects of care. So that's, we're social workers, we're nurses, we're daycare, we deal with the whole family. Why does our program work in Big River? Because it's community-based, it's community-driven, and it's community-developed. This program was developed with the chief, the council, the CEO, Derek, who's here today. Ruby's our health director. She's just come in the last couple of years, but it's developed with everybody. And our elders play a big part in this. We had a band meeting in the beginning that invited the whole community, and there's 2,800 living on reserve, and there's a 3,500 band base, but they were invited to come and say, what are we doing about this epidemic that we're dealing with? And so the program is not made in isolation. We're not the professionals that dictate what the community is going to do. It comes from within, and it very much comes from our clients. I'm a firm believer that those clients deserve all the respect in the world that any of us do. I'm going to get emotional on this, but they're someone's baby. What happened? They got on that track. And so they need the support, they need the respect that we all get when we go to see health professionals and just the day-to-day. And that's how we treat them. So the KOAS has a mobile unit. It's a mobile clinic. We mobile test our high school. We have a mobile clinic every 3 months in our high school. We find chlamydia, gonorrhea all the time in those students. We have found a case of HIV in our programming from our high school and Hep C. But our facts tells us when we're starting to get chlamydia and gonorrhea in that high school, we get in there and we hammer those kids with knowledge. And it's not pretty because they know everything's 100% preventable. You know, I'm not naive to say that I worry that it could be my grandchild at some time in my life, like what, you know, so that's why we treat everybody with respect. So high school testing is very much well received. We had to go to our school board, and then we had to go to the chief and council and the CEO to say, we want to do this. We test 16 and over, because they have to have a good understanding of what we're testing. Pre and post-test counseling in our program is, I'm trying to get it certified right now. I need clients to understand what they're being tested for and what could come out of that testing. The last question we leave our clients with is, what would you do if you couldn't come back positive for HIV? Point of care testing, the rapid test, we use very little. I'd say we've done maybe 5 in the last 7 years because our clients aren't ready for that immediate result. So we give them their blood test, we send them off, and they have 7 to 10 days to think about it. And we give them some homework to think about. If someone was really worried when they got tested, we'll touch base with them in about 5 days, you know. I know you're probably worried about your blood work, you know, and we just walk through some of the things, but they need to know it's not a death sentence anymore. We're not only dealing with the HIV, we're dealing with the addiction. Our clients are addicts. They continue, we have 90% suppressed at times, they go in and out of that 90%. And do we really know the 90%? Because we hope that we have 90% of the individuals in the community, but we're just not sure. And so we go through that with them, and we deal with everything in their case management. Sorry, I kind of got lost there. We have a very transient population. We deal with more than one community. Our mobile clinic also goes to 7 other communities that I supervise community health nurses in. And then we train their nurses to case manage their clients before we leave so that they're comfortable with what these clients need. Places that don't have a program, we talk to them about what will you do if an HIV client walks in today. You engage them. You ensure that they're engaged. You know, you take it one day at a time. Do they take up a lot of time? They do. We have our pests, as we call them. You know, they want to be in there every day. So from that, what have we decided to do? We've done a day program now. So the clients 3 days a week can come in and do crafts. They can do whatever. They're artists. They're smart. They're intelligent. We're looking at doing the grade 12 program out of the day program now. Our clients forget to dream. And so the one thing we tell them is you need to dream again. You can be anything. We just need to work with you in your addiction. Our clients are early detected because of the program, and it's well received. We have clients that actually bring in other clients or other friends of theirs that are doing high-risk behaviors. We have a seek and find program. We continue to test every day. It's a drop-in program. You don't need to make an appointment, and we'll do that. The diagnosis is powerful. We have found even clients that don't go on treatment, when they're diagnosed, they have that power now. This is my diagnosis, this is my disease, and I don't have to spread it. And we don't see the spread like we did in the beginning. We're getting very sporadic cases now because they know there's a program there that will support them and help them. Number 1 is committed staff. You need the right person to do the right job, and we have committed staff, and we have the right people in the right positions. So this is Charlene, who's our Suboxone worker. We have a Suboxone program that's direct observed, and they get carries on the weekend. And I think we have 17 in that program right now, and it's amazing. That's Ruby, the health director. Ruby's sitting here in the middle, and then one of our Know Your Status nurses, Amanda. Anyway, Jolene is our manager. Jolene is our manager. She'll take on my role when I retire at some point. She's an amazing young nurse, and she has been with me from the start of this program, and she has the passion that I do, and that these clients are number one. This is Dr. Crawford. We pulled him out of retirement. He's our Suboxone, our addictions doctor, and we absolutely love him. And he comes to community once a month and reviews the clients and their Suboxone, their opioid replacement therapy. We don't do methadone in our community. We just do Suboxone, and it's, like I said, it's well received. So that's our program in a nutshell. Sorry, I rushed through it. There's some contact names and numbers. And that's our program. Thank you.
Good afternoon, my name is Ruby McAdam. I'm Health Director for River First Nation. I'm going to be speaking on what we're going to be doing moving forward from here. Right now, we don't have a day program on our First Nation, so that's what we're going to be working towards 5 days a week, 3 hours in the morning. We're also going to be hiring a full-time RN to assist with our LPN, with our direct observed therapy for our Suboxone program, and we're also looking to eradicate Hep C on our First Nation. We're going to be looking into hiring a full-time nurse practitioner, because currently right now we don't have a doctor or a licensed nurse practitioner on our First Nation. We're looking towards a new health center to support our programs as we have grown out of our building that we currently are in. We're also going to be working towards establishing a relationship with the provincial government so we can have a better relationship. And we're going to continue testing within our community and engaging with our community members. Moving forward, my advice is to have a good relationship with leadership, because without our leadership, our program wouldn't be where it is right now.
Good afternoon. It's a privilege and an honor to be able to be here and share a story and to have this opportunity to showcase. And it's an honor to be here to represent my community as well. So I'm going to try and just change this up a little bit from yesterday. Big River is not very far away from us. They're about 10 miles away from our community. And so similar issues, similar programs. But I'll tell you a little bit about our community. Our community is about a 1,700 on-reserve population. We have about 3,500 band base. We have multiple services within our community, economic development, school. We have quite a valuable, resourceful community. We have a community health center, and we are community health focused, prevention focused. Our nurses within our health center, we're a little bit different. We are band employed nurses, so we work directly for our community. And so that, we also have a fabulous team that we work with, and our leadership has been key stakeholders in driving things forward. They're on the same page. They're very much they're leaders. They're our leaders within our community. Way back in the 90s, we started to see our high-risk behaviors happening in our community. And our clients were not accessing health services. They were afraid. They didn't have the trust in our community health center. And so we had two really brilliant community health nurses who learned and implemented our First Needle Exchange program. And again, with the support of leadership that was able to put into place. And our goal was, we were seeing increased, we were seeing hepatitis C increases. We were also needing those people to access health services. So through that, we were able to engage our clients, and they started to come little by little. They started to share and tell people. We would provide education. We had testing. We called her the STI nurse, eh? Arlene Allen used to come out once every 2 weeks, maybe for a half a day to do testing, and she was seeing just a few people. So we've expanded from that into having a nurse with the ability to do the lab work, and we provide those services on reserve. And it's a daily come in as they request. Anyway, our Know Your Status. We were seeing those increased in hepatitis C rates back in the 90s, and there was, the treatment was horrible, there was very lack of support, there was just nothing to support these people going through treatment. So it kind of fell off the grid. And as Leslie Ann spoke, we've seen the increase in HIV in 2011. And so then we started to mobilize and react to what was happening in the community. And similar services, bringing those services to our clients. Our clients were being discriminated in the off-reserve services. They were infected. They were injecting drugs. And in our country, they were Indigenous. First Nations people are, and you put those three together, and you walk through the door and you're treated very differently. I've worked in both systems, and I've seen it firsthand how Indigenous people are treated, and it's a shame how we treat each other. Okay, so our successes have been that we achieved 90-90-90, as Dr. Skinner explained what that was with the UN AIDS in 2015. And we've had ups and downs, and we've had, because of transient population, they kind of move around, they go back and forth. But that success has been attributed to multiple things, and bringing our services to the community so our clients they feel comfortable, they feel safe. Our clients, our nurses, Candice is here today, our clients have this amazing relationship, or she has this amazing relationship with the clients, where she just meets them where they're at. If she hasn't seen them in a few days, get concerned. We have Pat, who's our community caseworker. She lives in the community, and so her connections to the community are huge. She knows, oh yeah, I saw so-and-so at the store yesterday, or yeah, they're doing okay, or if we can't find them, they'll go out and find them. Tanis will, if clients won't come in for their blood work, she'll go to their home to find them and get those services done. Because it's just we want them to be successful, and we want them to feel supported. Those relationships are key to any success. Last one, I can't see what I wrote here. We also have a incentive program. It's incentive based, so clients needing some blood work, or kind of following and kind of rewarding them for being a part of the program and doing for themselves. So we give them food vouchers. Food security is a huge thing in our community, especially amongst our high-risk behavior clients. We also have, what is really unique in our community is the Cree Nations Treatment Haven, and it is a 5-week inpatient addiction treatment program, and there's also a 16-week matrix program, so it's an outpatient program, that part. One of the unique parts about Cree Nations is that clients who may be on OST, Suboxone, or methadone are accepted into the treatment program. That's part of their program. They have a very holistic approach where they look at all the aspects. The programming addresses all the 4 aspects of the individual. And they also do a day program where they have a nurse working Monday to Friday, and then there's a nurse for a few hours each day on the weekend. And they do the daily observed methadone or Suboxone for our clients. And as well as on top of that, we've integrated the ARVs and the hepatitis C medication, so that we've got that additional support. So it's a huge partnership that we have with them, and it's a big piece of our success with our clients. Peer involvement. We have one of our other caseworkers is a peer, and we also just have, I shouldn't say that, some of our clients are peers. They advocate for us to bring the clients in, their friends or network. If it's a safe place to go, it's a good thing. You need to go see Tanis at the clinic, just go have a conversation, or go see Pat. We have a needle exchange program that still continues, and Pat manages that. So when the clients come in, they have a conversation, and she said sometimes, you know, they just ask her to pray with them, and that's all they need. They just need that support of someone who's going to listen, someone who's going to just be there for them. And so we indirectly work them into our program. We started an expansion program of our Know Your Status last year within our leadership, and our health director at the time wanted to, eliminate hepatitis C. Dr. Skinner brought in a gentleman that did some lean consulting work with us. We had no extra resources, so it was looking at what we could do with what we had to best meet the needs of our community. And so through all of that, the biggest piece, I think, that we've done liver screening events, and then we follow up with clinics. And it's a nurse-led model, and we're learning every time we have a screening day. We learn and we learn, redo and redirect, just to make it better. And I lost my thought there about where I was going. So our clients, when we first started building the program, it's like, as a nurse, I'm a band member. I grew up around the community, and we know as health professionals, we know what people need. We think we know what people need. We know what they have to do, and we just want to fix them. And one thing that I've learned is that we need to listen to our clients. They know what they need, they just may not know how to get there. So one of the things that we did as part of the planning of the liver screening was a focus group. So we met with our community members, elders, and clients that had been involved in the program or were living in the community, co-infected or substance use. And our community members really just wanted a well community. Let's just make everybody better. Let's get rid of this. And so that's really their direction. We just want a good, healthy community. And our clients really just wanted non-discriminatory care. They just wanted to be treated like anybody else. And I shared yesterday that what really rang out to me and kind of is always in the back of my mind is one of the clients said, I did not ask to be addicted. I did not ask to be infected. So simple words like that, it really raised a lot of, you know what? I didn't ask to fall down and break my leg, and I got good care, right? So it's just a matter of choices. Anyway, I could go on and on about that. So we've had some liver screening events and then follow up with clinics, and we've started treatment in cohorts of 6 to 8 people at a time, just to make nursing more manageable, to work with the clients with the blood work, but we also, it's so that they can support each other through treatment. We have a support group there where they can come and go as they please, just to have those extra support. Sometimes just to come and listen, and sometimes it's to share their stories. So that's coming along. It just needs a little bit more media in the community about it from peer to peer. So one of the things when we look at engaging our community and our population in anything is, like I said, we all think as health professionals we know what the answers are, but it's about looking at the whole team and partnerships, looking at the partnerships. And when I say partnerships, I just don't mean our partnership with the federal government for funding. I'm talking about those partnerships and relationships with clients to the bureaucratic level where we do get our funding. And we need to be those advocates in between. Partnerships and advocacy go hand in hand. We need to be open-minded and allow for those relationships to build. Communicating. We need to continually communicate with each other. We need to communicate with our clients and listen. When I say communication, I don't just mean talking, listening, really good listening and hearing what's being said, and actually sometimes having to change your own outlook on things and moving forward. And addressing culture. Culture, our community, our Indigenous people have have lost a lot of their culture. So looking at ways to help support them to find that culture. I was listening to one of the community members, and he was talking about the 70s with all the drugs and how it grew and grew and grew and grew and grew. And he talked about the culture of how those drugs came, and it just became a normal way. That was about a timing of when our culture was really lost within our communities. So replacing, I don't know if you know what I'm saying, but you're replacing one culture with another. So supporting those positive cultures, whether they believe traditionally Christian-based, land-based learning is something that we're going to integrate into our programs going forward. And it's so that people have that place to go where it doesn't matter who you are or where you came from, but connecting with the earth, connecting with the activities on the land, and learning some of those traditional activities to help move them along. And going forward, we're just going to continue to keep asking for things that we need based on what our clients and our community is asking for, and that ongoing advocacy. Expanding our services. As I said, we're community health based. Our nurses are community health nurses, public health nurses, and we're working, as Leslie talked about, and her nurses with the expanded role. So we're kind of moving into that primary care piece. So advocating for those services that we need for our people, and working with leadership. Our leadership are key in our community, and working with awesome partners like Dr. Skinner and his team, and even our neighboring communities, supporting each other. And that's about all I have to say. Thank you.
How you doing? Hi, I'm Matt Goldberg. I'm one of the chief medicine residents. Thank you so much. That was an outstanding discussion and a very inspiring story. When we have an initiative like this, it seems like it takes a critical mass of buy-in from community leaders, healthcare providers, the patients, or just family and friends of the patients to get something like this done. And I was wondering, in terms of getting this started with such a daunting task, I imagine you were met with sort of resistance and at least defeatist language about how could this even be done. And what strategy you sort of employed to overcome those sort of obstacles along the way?
Is your mic here?
You can put the stock mic.
Okay. Can you hear me? I have a loud voice anyway. I think in Big River, how we first began is that leadership. You needed to have your leadership because what comes with a program like this can come stigma and discrimination from rural Saskatchewan, from the non-First Nation population. Because when we started with 30 cases of HIV, and next thing you know on social media we had 780, and then the next thing you know the whole reserve had HIV. So it was just having that support to move forward, because when you get your leadership, and when I talk about our chief and our council, that's our government. And so when we have their support to move forward, we can do anything. And then you built the program, and it was so inspiring because they see the immediate results. We also started the program with no money. There was no extra money. And the big thing with that was getting people to quit doing stuff that wasn't part of their profession. Like our nurses were driving, they were filing, they were doing all kinds of stuff, and that stuff needed to go. And so we had that support from, again, the leadership to not have to do all that non-nursing stuff, where we could focus on the priority and the epidemic that was in front of us. But there are communities in our province that are not willing to take on the KYS yet because of those issues with the stigma that's going to come with it and the discrimination. And so it's education. You need to educate your community. You need to let them know the outcome, how much better it's going to be for our professionals, for our community members, for our family members. And they just seen that it was such a success in the beginning, and we have many of the families that are involved in their brothers, sisters, sons, daughters, grandchild's care now. So you have to have the support from your governing body for sure, because then nobody can debate it with you, because they're telling us to move forward. And they have to know what we're moving forward though. So our program lives and breathes with our governing body, our chief of council, because they're the ones that go out and get questions, so they have to have that knowledge of what we're doing. Does that make sense?
Yeah.
That answer your question?
So we have opportunity, and others of you who may wish to respond to Matt's question, please go ahead. For the other audience, we'll take your questions and comments, and please identify yourself when you ask your question. Anybody else want to reply to Matt's question before we turn to others?
I think let's
Yeah,
answer that
Preston Reynolds, Department of Medicine. Thank you. It's really wonderful that you love the people that you live with so much. Talk to us about how the community itself has used their relationships with their own family members to help expand and spread the program. Do they encourage their children to seek out this knowledge? I mean, what's the level of acceptance of the people themselves in spreading, building, promoting, and expanding what you're doing?
So again, for Big River, I'll start in our area, and Noreen will expand on what they're doing. Just getting into that high school, and when you get into high schools and you're talking sex and you're talking disease and you're talking about these kids having sexual relations, many people don't get that opportunity to even get into their high school. So to get that permission from the parents and from the leadership to get in there and promote all of this program, and there's no sugarcoating. This is how it is. This is 100% preventable. You kids need to start taking care of your bodies. Your body is your temple. Those conversations and just having that permission from parents to talk to their children about what's happening in the community, about the drugs being abused. We started with morphine. We have prescription drug sellers in the community. Our clients are now leaning towards crystal meth, you know. Those kids are aware, because I see that school as those kids are our future drug addicts or our future diabetics or our future everything, and they don't have to be. And so I would say the community embracing us, getting into that high school on a monthly basis and filling those kids with so much knowledge, that I think that in itself speaks for what we're doing, because people want to shelter their children. You know, you're not going to talk to my grade 6 child about sex and drugs and you know, people used to think you're promoting it by doing it, just like the needle exchange. Oh, you're promoting drugs by giving your needle exchange program out. No, we're not. It's harm reduction. We're not finding the dirty needles in our communities anymore. Our clients are coming in, and it's called needle recovery. You bring your needles in, I'll give you back. You're using 100 times a day, you're getting 100 needles. Because we showed the one client shared, you know, had 23 contacts and 19 were positive from a weekend of sharing. So that just speaks in itself. So I think just by all the things that we've brought forward in this community rapidly, because this program went like wildfire. And just for what we can do in this traditional, culturally based community, in itself speaks for the clients knowing, I want to protect my children. And that's the conversation I have. We need to protect our children. We need to protect our grandchildren. We need to fill them with the knowledge to go out into this world and manage. Because there's a lot of scary things in our world nowadays. Drugs and alcohol are one of them, and intravenous drug use.
And I think just one to add to that is we still have family members and community members that are fearful. They're fearful for their relative that might have a diagnosis. And I think it's just having those difficult conversations with people, and really that ongoing community-wide education. Like educate, and just having those open doors to have those conversations.
Hi, my name is Carolyn Engelhardt. I'm on the faculty in the Department of Public Health Sciences, and this is for Dr. Skinner and the rest of you. So in the United States, both private insurance and public health programs resist access to very expensive pharmaceuticals for hepatitis C. In Canada, you have price controls for pharmaceuticals. So my question is, do you find that your patients have adequate access to those kinds of drugs when they need them?
Yes, we do. I don't, like, the cost of the drugs, at least the list price, like say, it's about $20,000 per month. So I mean, the costs are still significant, and there's a debate that always goes on about, you know, well, they're just gonna get reinfected, and, you know, we're wasting money, and there are groups, you know, there are physicians and bureaucrats who would argue that, no, we shouldn't be treating them. You know, we're one of the most aggressive treaters of people who are kind of actively using. And part of that is it comes back to treating that individual as a person, right? You can, you know, they should be offered the same treatment whether they're using substances or not. And it really builds the trust and relationship for me as a physician to those patients when you can offer them a cure. And they take that and they take it on and they say, okay, you know what, this is, I recognize the opportunity and I'm gonna try. And you know, addiction's a chronic disease and relapses happen. And I never say to someone, you can't ever use again. I say, look, you need to be safe. But they take it on, and the number of people who've come back in 3 months, say, you know what, I haven't touched a needle in 6 months, and I haven't drank alcohol in 6 months, and I'm going back to get my grade 12. It's really been inspiring to see them kind of take that illness on when you kind of provide that opportunity for them. I also believe from a public health standpoint, the #1 priority to treat should be people who are actively using. Because if we actually want to make a dent and stop the spread, like Noreen mentioned cohort treating, so I was like, well, why are we just treating this one person? Because you're most likely to get reinfected from your spouse or your partner or your friends who maybe you're in the same group. Let's treat, you know, if we can, right? Let's treat the network together and let's get rid of this virus out of your group, and try to take it on from that public health perspective. The coverage is pretty good. Like in Canada, it's F2 or higher, or if you're HIV co-infected or hepatitis B or a young pregnant woman or woman of pregnancy age, diabetic, fatty liver, transplant. That's kind of the current criteria. My understanding is coming April 1st, 2018, it will open up for everybody. But I mean, what a horrible thing, right? You say, hey, we've got this great cure, it's like placebo, we're gonna get rid of it, there's no doubt about it, but you can't get it. And it really, it's deflating for people. It's deflating as a doctor when they can't get that treatment. So we really use it as an opportunity to engage people into care and engage them, like I said, beyond, like they all get into mental health and addictions programs as part of that treatment package. And I don't think we can look at Hep C as an isolated illness. We got to look at it together and use that opportunity to, I mean, anyone who can now have a cure someone, it's motivating for somebody to influence behavior change.
So I have 2 quick questions. One, you really demonstrated, first of all, remarkable story. Thank you for sharing it. It's so inspiring. You're doing something that we rarely do, in my experience in this country, which is really outreach-based healthcare. You're getting out there. In my experience, having done that, it was a really joyful thing to do. It really enhanced the meaning of my work to get out beyond the clinic walls. So what's been the effect on your staff by this program that you've done? And then the second is, what was the added thing that the peer program brought to what you were doing when you started it?
Well, I can speak on our staff. We have, because we have erased all that non-nursing stuff that nurses don't need to be doing, we have staff that are so satisfied with what they do. It's amazing. And like I said, they're passionate, they love coming to work. We just had a nurse off for a week. She goes, oh, I'm so glad to get back, you know. Like because we're doing new things, we're groundbreaking. They feel like they're part of something that has really been recognized nationally, and they just have great support. But our staff satisfaction is up there. And we're all on the same page. And go ahead, Steve.
No, I just same thing. Are most people physicians? Is that kind of the happen a little bit? You know what, like, I love it. Like, it, for me, is rejuvenating. You get out, and it's like you're doing something. You know, I see people, and I'm like, if I didn't come, you might be dead, or you might get healthcare. I know that's kind of egocentric to think of, like, but, you know, but you're part of a team. So I look at it, people say, well, I can't do that, and there's no way this would work. I'm like, I go out 1 day every 3 months. So 1 day every 3 months I go to Big River, 1 day every 3 months I go to Ahtahkakoop. We hit the UN AIDS targets, we're eliminating hepatitis C, and now we're building chronic disease program. And that's happening with such a small amount of time. Like, the physician, I'm the least important part of the program. What we're doing is a team-based approach. And it's such a small thing, it doesn't take much to have a real tremendous impact. The unfortunate thing is, right, I mean, as physicians, we're listened to, right? Whereas, you know, the other members of the team should be listened to equally. But we do have a powerful voice, and we can bring that even with that 1 day every 3 months. And it's for me, it's rewarding. I love, you know, working. I love the patients. I love working with these guys, and just even getting out to a real kind of raw type of medicine. It's been tremendously rewarding.
And I think one of the most rewarding parts, and is up until 6 months ago, and we started the program in 2010, the formal program, we had no hospitalizations. Our clients were completely case managed and healthy. But up until 6 months ago, we had a client pass away, and what got him was his uncontrolled diabetes. So they have other illnesses and chronic illnesses that we're trying to, because you got to deal with the whole person here. We're not just dealing with their HIV and Hep C. We're dealing with their mental health. We're dealing with all those aspects of care. And so, and like I said, many of our clients, and I'm sorry, but I do use the word addicts, many of our clients continue to abuse drugs and are addicts, so we're still dealing with that. But the rewarding part, and this is why our provincial counterparts, we try to tell them, do you know how much money we're saving you by not having any emergency room visits, no hospitalizations in 7 years, like, you know, give us a phlebotomist every 6 weeks. Like, you know, it's just, to me, it just makes no sense because we were proven. And so that it is very rewarding. I go home at night, some nights I'm sad, but I feel good because I feel good what we're doing.
Go ahead.
Karen Mon, Family Medicine, also Canadian. I also want to echo the gratitude for you sharing your story. It's incredibly inspiring. I had 2 questions. One, have you seen any collateral change in your addiction rates with all this education? It seems like education is the #1 key thing that you're doing. The second question is, you must also be incredibly inspiring to your youth. You're going into the high schools, you're educating them like they've never been educated before. Are you using your youth at all to go out and educate as well in a peer-to-peer fashion?
Just comment on the students. We do various programming aside from nursing and multiple programming, and a lot of the ways that we utilize our students and the school is with reflective learning. So we give them the information, we run a contest, a poster contest, a poem, a story, whatever it might be. We offer them a classroom incentive for a pizza party or something like that, and they come up with these amazing posters and wording and messages after we've given them the information, and then we display it in the community. And so they have that opportunity to have those conversations amongst themselves and show what they've learned. So that's some of the projects that we've done.
And our students are very much ambassadors to our health program. I've had numerous conversations with people that said, oh, I've talked to some of your Big River band member, the high school students at one of our sporting events, and they know so much about HIV, and someone was wearing a hoodie that said KYS, and they said, what is that all about? And she said they were just able to explain it with almost the passion that we teach it. So that felt good, because they're getting the message. They know that everything is 100% preventable, and they need to protect themselves.
We are at the end of our hour, but I would just like to say on behalf of our audience, you all are amazing. And the programs you've created are also, and you know, a part of it is the energy and the passion and commitment that you all have brought to this. It's really quite inspiring. Our program next week is the opioid epidemic's impact on public health and patient care. looking at the situation here in the US and here locally with Richard Bonney from the School of Law and Leslie Blackhall from the Department of Medicine. So to our audience, we have a week to think about, how might we begin to mount some local efforts kind of out of our own community to begin to meet some of these challenges, health professionals and students and others. So please join us next week, and now please join me in thanking all of our speakers.